Okay, everybody. My name's Martin Kiernan. Along with Brett Mitchell and Phil Russell, I'm one of the co-hosts of the Infection Control Matters podcast. We did one of these last year live on stage. To date, that's got about 1,200 downloads from about 100 countries dotted around the world. Probably people who listen to about 5 seconds if they don't understand English or Australian English. And I was asked if we'd mind doing it again. So here we are. And I've got a fantastic panel alongside me here. I've got, I'll start from the far end. So we know Dr. Mark Garvey. This is really for people who are listening afterwards when they're bored on the train, rather than us in the room. Dr. Stephane Bouchoucha from Deakin University in Victoria. Lorraine Williams from Hertfordshire, who's the Deputy Dipsy there. Kerry Holden from Gloucestershire Hospitals, Deputy Dipsy there. And Moira Smitty from the University Hospital Cork, is that right, where you're a senior lecturer? University College, yeah. So we have a nice panel here to have just a general discussion, and I'll chuck a question out to start with, but I'm rather hoping you guys are going to chip in as well. So here's the first one then. If you look at national prevalence studies, infection rates are either static or going up. Why are we failing?
It's a small one to start then.
Go on, yeah, it is a small one. I'm maybe not failing, but why are we not succeeding then? Anybody want to kick off on that one? Mark, come on. You look like you're reaching for a microphone.
Well, yeah, I can have a go. I think for my experience from looking at the infections at the moment, where you see the general trend up, I think there is a bit of like a COVID after the COVID pandemic, a bit of blues from it all as well. It was very interesting seeing the last slide at the end. Obviously, put some who in the audience around vaccine data. It was quite interesting where you saw like the vaccine levels are down to about, for healthcare workers, at 40%. Now, when was the last time looking at that graph? We were 40%. What was about 2010? So if you look at like the infection levels, is it sort of going back to where it was? I think people have got vaccine fatigue. There's especially in the UK from a healthcare position, the healthcare was under such stress during the COVID pandemic that there's been a massive focus of getting patients back in for elective care, for for elective surgery, emergency. People are staying at home. I think infection control's gone off the radar a little bit. And for me, it feels like we've gone back a bit. We had loads of resources during the pandemic. I think those resources have been taken a little bit away from us, and it's just not the focus. I remember you were saying yesterday around targets, didn't you? I was saying targets was actually, they did quite well from an MRSA point of view. The targets are they don't really mean anything now from a UK point of view. Whether that new NHS framework might have a difference.
Are there any targets that you know of?
Well, gram-negatives and C. diff, and there's a new NHS framework that has come out, whether that will make a difference, a 10-year plan. The big focus is on that, is around elective care, 4-hour wait times, your cancer referrals, and then within that are C. diff and E. coli and MRSA. Would that make a difference? I don't know. My board's, for the first time in about 5 or 6 years, is asked to see those numbers again. So I don't know. But I think from me, certainly feels like a bit of COVID pandemic blues.
Okay. Kerry, Lorraine, you're both Deputy Dipsy, so presumably you'll get involved in reporting to the board. Are they bothered at the moment?
I think they are. I mean, it's interesting actually, a reflection what you said, Mark, is that I do think those more those HAIs that are kind of taking advantage of the cracks in the system, maybe. Interesting reflection in the southwest that we saw in a particular area. I think it was Dorset. They saw an increase in C. diff infection rates, particularly in men that were on elective pathways for urological procedures, and they were finding they were having more and more catheter insertions during their stay, and they saw an increase in their C. diff and in their gram negatives, just that correlated with the elective recovery. And actually, I don't think we necessarily consider sort of looking at all those metrics together about the harms of the delays and the inputs of people being on waiting lists. And I think that's probably the way in which we've been able to maybe hook some of our boards in, if I'm honest. Yesterday you referenced make every kind of outbreak or incident, a matter to make a difference. And that's probably why I've probably got some of the voices of some of my board colleagues, because we've had issues and people want to hear about what we're doing and they want assurance of that. do they necessarily look at the thresholds? Probably not so much, I don't think, from my point of view. But what they are wanting to see is, I think, patient experience from our chief exec is very much at the forefront of what he wants to see now. And we're a clear indicator in that. So he wants to know, actually, we don't want patient being harmed by our care. So I don't know if that's fairly a unique CEO, but that's somebody who's desperately wanting to see that change and wants assurance of that.
I completely agree with you, Kerry. I think, though, that we have to get better at using data well. And we can't be chasing targets or thresholds. I think we absolutely need to focus on patient experience. But we also need to have a real joined up approach, because it was mentioned earlier in one of the presentations that I was in that, you know, we are focusing on our sepsis response, and that's completely right. But we also know that our sepsis response involves broad spectrums, and we know the effect of any antibiotics, but especially broad spectrums. So, you know, on one page we might be looking at C. diff numbers, and literally the very next page of a performance report, you're looking at, you know, our sepsis response. So I think we also need to help our execs and our teams to understand that we have to have a joined up approach about what we're dealing with and the consequences of one metric against another. So I think it's about really for us understanding data and using data well to inform our colleagues and, you know, and our clinical colleagues too.
Stephane, you're president of ASIPSI. What are your members saying to you about, you know, has it got on the back burner in Australia? I mean, I know you don't do national prevalence studies.
I was going to say this is a good question, because we're not measuring anything as such. It's all healthcare is devolved to state and territory. There is no national surveillance, consistent national surveillance, which is something that's going to come soon, apparently. So there hasn't really been so much discussion. I mean, there's no targets as such or anything like that. So it's really, we're not measuring it, so we don't
have a problem then.
Exactly. So I think we will probably have a problem. We will have a problem when national surveillance comes in, which is fairly soon. We're just doing some work on getting the indicators and what they want to be measured. So we're very much at the planning stage of that compared to what's happening here.
And will that be the new Australian Centre for Disease Control, ACDC, the coolest ever agency?
Yeah. So,
because you're not involved, are you?
No, we're not. That's another really an area where we've tried to do a lot of work with the college. So the legislation passed a couple of years ago now for an Australian CDC, ACDC, to be started. The legislation was put to Senate, being put to Senate a couple of months, but IPC is not part of the CDC. So the idea of the government is that we have an Australian Commission Quality and Safety in Healthcare that deals with healthcare-associated infection. So therefore, they do IPC. CDC doesn't need to do IPC because obviously infection only happen in healthcare. As we know.
Not
we all
quite
know that.
correct, though, is it?
Yeah? No, but that's the biased view, which is what we've been trying to do a lot of advocacy work to really bring IPC within a CDC structure. Because when you look, when you look at the CDC, it's within that. When you looked at what happened in the CDC previously, it was part of the CDC. So in the US. So yes, so that's really a little bit of an oversight. And an oversight is probably not strong enough. But so yeah, it is really difficult landscape to make people understand that, you know, infection, IPC within a CDC framework would benefit the community. And we all know that here, so I'm preaching to the converted, but that's really is something that we're trying to get going.
Okay. Maura, you got no national surveillance system in Ireland, is that correct?
No, we're similar to Australia like that. Now, you obviously do conduct surveillance on bloodstream infections and C. diff and things like that, but there isn't any surgical site national system. So that is something that, you know, needs to be addressed at a national level, so we have comparable data to see where different sites that are comparable and how people are performing. We do participate in point prevalence studies, but looking at and listening to what we've been hearing in the last 2 days, we also know there's a huge piece like data for action is so important, but then how do we motivate people to engage with these surveillance systems and do it if we don't legislate for it? And I think there's a huge amount of fantastic work being done in Ireland and obviously other places in more piecemeal surveillance where people are collecting their data and they're benchmarking against international data. But the other side of it is we do need to look at the patient experience as well. And I think sometimes it is the patient story and the patient experience that will actually engage people in surveillance. Because a lot of the time we're all really, really busy. We're all passionate about infection prevention and control. And sometimes, not that we forget that we're doing it for the patient, but I think other people might forget a little bit that there are real people and not just numbers. So I think we really need to engage our patients' voices in co-creating or thinking about how we implement things and how we use that data for action then.
Okay. I mean, you've done national prevalence studies in Ireland. Have things got better or worse, and are people concerned about that?
I don't think we've done one in a couple of years, and I think we're pretty reasonably steady. But I mean, like everybody else, resources were there during COVID. Things have changed. We have slightly different structures. We have a fantastic national team, the Antimicrobial Resistance Infection Prevention and Control team, who are going from strength to strength from an acute perspective and a community perspective. So there are big changes there, and it's a more consolidated approach than we would have had previously. So to date, a lot of it has been policy and education focused. So I have no doubt that the next thing in line for attack is surveillance, hopefully.
Okay.
Yep.
Okay. Anybody in the audience want to throw in anything on that one? I'm staring around. Oh, yeah, there's a hand up there. Lisa, can you trot down and use the microphone? I do apologise.
I don't think we're failing. I think that what's happening is that to get into hospital now, you just need to be really, really, really sick. You know, we've got over 100 people in our place medically fit to be discharged, but nowhere to go. So we haven't got enough beds. So to get into hospital, you've got to be really sick. And you come in, you're old, you're deconditioned, and I think they're staying longer and just picking up more, as we heard about pneumonia, cortis, and they're staying longer and they're sicker. And I think we just can't keep up with it anymore. I think it's become really problematic in terms of, if you look at our surgical emergency unit, our activity for June, July and August this year has gone up 12% compared to last year. So that means we've got more people waiting to get into our emergency theatres. We haven't got the capacity. They then get a gram-negative bloodstream infection and, we start all over again. So I don't know if that's true of others, if you're seeing an increasing number of medically fit patients not being able to go anywhere. And, we're not getting people in quickly enough.
Yeah, it'd be interesting to know if there's any data on that. Lorraine, you wanted to make a comment?
I did. Sort of slightly different and a bit of a chink of kind of sunrise or sunlight. With the focus, certainly in England, so this is a bit England-centric, the focus on really joining up sort of place-based care, so thinking about closer integration between acute care, community, primary care, and others, and also with social services within a place is a brilliant opportunity to link up the patient experience really from home through to acute care, or, and then back home again. So actually, I think on the horizon, we've got an opportunity to really focus on even some actions we can help people within their home. I think one of the things that did work really well during the pandemic is that the general public had a lot of information about how to protect themselves and others. And actually that's really fallen off. And perhaps this is an opportunity to, again, think about joined up care where the person is more in control of their sort of destiny.
I mean, it's interesting, the infections in your own home, because I do remember Luke Moore published a paper from London where they looked at E. coli, or gram-negative bacteremias from the community, and they dropped dramatically during COVID. And why would that be? Why would people suddenly stop getting gram-negative bloodstream infections, non-hospital acquired, during COVID, not going out? What are they doing when they go out? nobody has any answer to that. It would be fascinating to know why that happened. If anybody's got any great ideas, I don't know. But what we also find is in long-term care, people pick up infections. We're recognising that they're requiring readmission to hospital. Is there anything we can do about that? Because I think COVID put quite a focus on infection prevention in long-term care to demonstrate the devastating effect of being unsupported from an infection prevention point of view, but also the burden it brings back on acute care. I know, Stephane, you've done some work in this area.
Yeah, we have. I have, and with some colleagues. But I think what happened in Australia with COVID, I mean, it was tragic in a lot of long-term care, residential aged care homes. So, there's been very good at doing world commissions in Australia and inquiries and I think I counted there have been 24 inquiries since the beginning of COVID up to now on COVID and management of things and pandemic response. But one of the outcomes was the mandating of aged care, infection prevention aged care lead nurses that need to be registered nurses or enrolled nurses, because we still have a lot of, we still train enrolled nurses in Australia, and have an IPC qualification and need to have dedicated to be employed in a facility. So we haven't seen, I mean, it's really hard because of lack of surveillance. There are some quality indicators for aged care that needs to be met and reported, but they're not really public, so you can't really determine the impact. But it'd be fascinating. So we're doing some work with looking at incidents of catheter-acquired urinary tract infection, how they manage in residential aged care, because it should make a difference. There are a few issues because a lot of the pay in residential aged care homes is much less than in acute care. So therefore, these nurses get a qualification and then decide to go and work in a hospital as an infection prevention nurse because they get better recognition. And also there is a legislation to mandate the qualification, mandate the position, but there's no mandating of quarantined hours to do the job. So that's another...
It's an add-on role.
It's an add-on role where you have to do a qualification at a master's degree level. So there's a lot of... It comes from a really good place, but there's a lot of things that are still being worked out 3 years later. So,
no, but that's a considerable step up from a linked nurse system, isn't it?
Absolutely.
Where somebody gets rudimentary training. Here you've got a mandated amount of training. And if it does mean people come into the infection prevention professions through that route,
absolutely,
hopefully they're enthused to think this is a good career. Because my feeling was during COVID that a lot of teams were given people and people came into infection prevention teams and they learnt COVID infection prevention. Are they staying now? Can we train them? How do we keep them? How do we keep good people? Any ideas how we keep good people? Did your teams get bigger during COVID and what's happened since?
They absolutely, they absolutely did get bigger. And I think the worry is, I think in England at the moment, I'm probably seeing quite a few of my colleagues in integrated care boards at the moment that are worrying that we are going to lose that amazing sort of resource that we have now that are really targeting supporting care home environments, residential primary care, kind of adult areas where people are living. And we're trying to drive, the NHS plan says driving into community, and we're potentially going to risk losing all of those people. I think it's a real risk that we have. And those people aren't, just the kind of plasters that were brought in for COVID. Some phenomenal work coming through, particularly about hospital avoidance, admission avoidance. I even think from my own ICB, we've seen fantastic work in mouth care prevention that's happening, improvements in catheter care management, improvements in hydration, fundamental care aspects in those environments that those IPC practitioners have been able to instill have had a massive positive knock-on effect on how we see the healthcare system. And I really worry that funding that's going to go for those people is
Why
going to have
we
an
lose them
impact.
though? Because if they're that effective, maybe we're not quantifying the benefit and able to prove their value.
Try not to get too political.
Oh no, get political. There's no problem with getting political.
I don't know, because I don't think those IPC nurses and ICBs sell themselves short. I see their value every day. It was a shame that I think the feedback that was given in terms of where these where the staff cuts can happen was IPC was where I think where we had the dartboard on our backs, and I think it's really short-sighted, particularly with the COVID inquiry going on, to say this is where the impact of those environments were hurt worst, and we're not going to be investing in the people that will make such a difference in that. I think it's really short-sighted, and I think it will come back and bite us in the backside, if I'm honest, if we don't. And I know our ICB colleagues are really fighting to keep their posts at the moment.
The thing is, it isn't us that will bite, is it? It's the organisations and the patients.
Exactly.
Lorraine, you wanted to say something?
Yeah, I wanted to say a couple of things. One, I was talking to Tracy at lunchtime, and we were sort of reflecting on the cyclical sort of feast and famine of IPC ends, or the IPC provision. And actually, we've got to really guard against going into a famine post-COVID. And I think we also have to be really good at speaking executive speak as nurses. Now, I'm not saying nurses aren't execs or can't be, but I think for a lot of us in the IPC team, that is not our natural language. And we do need to articulate the value of IPC in a way that is compelling, in a way that affects the bottom line in a positive way. And one of the challenges about IPC is it's very hard to quantify what we have prevented. And that's absolutely what we need to do. I think the other thing is we've got to keep the people that joined during COVID, because when others were, we were all afraid, quite frankly, but when others were afraid and, were worried, many people were afraid and joined the IPC teams. So we have a cohort of very brave IPCNs or CSWs or, micros or whatever, the team. And surely we need to be thinking about what can we do to encourage them to keep growing, to innovate, to tackle the challenges that we have right now with that same spirit. But it's down to us as leaders to articulate that.
Moira, what's the feeling in Ireland?
Well, I think our guidance and what's required is governed in Ireland by the Health Information and Quality Authority. And during the start of COVID, it was mandated that every care home or residential care facility would have a designated person for IPC. However, the associated information in terms of hours or qualification were not stipulated. So while we have definitely seen a massive, massive, massive improvement in those settings in terms of expertise, and there was obviously funding then for training that was associated with that is still existent, which is fantastic. And I think because it's part of regulation, that will embed and hopefully will embed more. And I don't think we're in terms of at risk of losing it or going backwards. So I think it's very positive, but I think it could be more positive with, guidelines on how many hours a week does someone need for so many beds? But it's the age-old story of how long does an infection control nurse need to be in place per how many beds?
Yeah.
But I do think the other thing, part of it is that we need to probably step outside. And you talked about speaking the speak, Lorraine. I think we need to step outside healthcare and talk to people, talk to the public. All those infections that didn't occur during COVID, there's a reason they didn't occur. How many of our grandparents or maybe our elderly parents know that you should have good dental hygiene to prevent pneumonia? But really, if you just drink some more fluid, you might reduce your risks of UTI. And I think we need to go broader than healthcare to develop a strategy to prevent infections, to be honest, yeah.
Okay, thank you. Stephane.
Do you think, we had all these behaviors during COVID, so have we failed to capitalize on that? And have we failed in a way I've been thinking about that. That sounds like I don't have luck, but I have been thinking about that. We had all these infection prevention behaviors, and we have not really, as a profession, tried to sustain that. So I don't know how we could have done it, because there's so many different, competing priorities. But it is something that I feel we have missed something here. And can we pick that up now?
I think there is opportunity too. I was lucky enough to be involved in something for the Department of Health at home in Ireland, in looking at patients and staff stories of sepsis and antimicrobial resistance. So there's a lot of qualitative work, a lot of chatting to people. But the stories that came out of that it's heartbreaking. I think sometimes people don't think it's not going to happen to me. Sure, we're fine. I don't need the flu vaccine. I'm perfectly healthy. And, people don't realise the impact of infection, and they don't realise that they can take control. And I think the whole thing during COVID was people needed to have that level. They were terrified. Everyone was terrified. And they felt that if they did certain things, they had some level of control over their risk. And I think we need to really share that again to explain to people you can control your risks in terms of infection in a much broader sense, in terms of preventing infections, reducing hospital admissions, and quality of life, really. I think that's, we need to be looking at quality of life and protecting our populations and also protecting our healthcare services.
Lorraine's desperate to jump in again.
Well, I wanted to sort of reply a little bit to what you said about, kind of wasting the opportunity or not taking hold of the opportunity, preventative. And I was thinking, we can make small steps now, can't we, to capitalise. I think about winter. And, I read the leader report a few weeks ago, and I was really struck by avoidable deaths. And I was, one of the highest avoidable deaths. And this is for people with learning disabilities and autism. Please do read it if you haven't. Was due to respiratory and flu-like illnesses. And I was thinking, well, we have community nurses, we have school nurses. Have I ever spoken to them about what are the vaccination rates within, your special schools? And actually, I started thinking about these are really good ways to start reaching out. And then I spoke to somebody who works in a special school, and they were saying, well, it would be great if we could get some teaching for our teachers and maybe some information we can share with the parents in order to help the parents to understand the importance of vaccinations. And really, that's a quick win for us. And, for some of you, you might think, oh, yeah, well, we've been doing that for 10 years, but we haven't. But it's a quick win to start reaching into the community and helping them to think about what they could do to prevent some of these things.
I mean, people don't make the linkages. In that last session, we just heard how flu vaccine can prevent many cardiac issues. If you asked 100 people on the street, well, the flu vaccine, what other benefits will it give you? I bet hardly any of them actually say, well, it might stop me getting cardiac issues. So, and patients don't know cleaning their teeth to stop themselves getting pneumonia. Brett's just done a study in Australia, just completing, and we give patients a toothbrush with "use me to prevent pneumonia" written on the toothbrush to try and get some sort of linkage going, try and get some sort of connection going. Now, many of you mentioned resource. So I'm going to give you a scenario now where I'm going to give you either £1 million or €1 million, or given the exchange rate, $20 million. And you can do one thing, one intervention, or target one organism. Mark, what would you spend £1 million on?
What would I spend £1 million on? I would spend randomly probably £1 million on getting lots of data. That's what I would do, because I think data drives everything that you do. Everybody's been talking about a little bit, saying, oh, infection control makes this difference, that difference, this difference. But if you can't, the organisms we can't see, can we? I've said it. You heard Jack Gilbert last year saying how many organisms we got on us, and we expelled them. If you had full of creepy crawlies, people would be doing all kinds of stuff, wouldn't they? If you had bed bugs, they're scared as anything. If you could see the bacteria, then you would do that. And I think you need to be able to quantify that stuff, because I think if you can quantify it, you can do visible things to it. If you can show that data that you have, what benefits it has to the patients, your length of stay and all that kind of stuff, you can make the differences. When I talked yesterday about the CPEs, but when you look at the cost of the antimicrobials that we're giving, it's going up 6% each single month. So we spend £1,000 on CPE antibiotics every single day. So you could talk about, I want to put a different cleaning agent in, or I want to do something. Well, you just need the time to do that. I find working in my trust, we have great ideas of what we can do and hit doing that, but actually having the freedom to go off and do those kind of abilities, because you're doing your day-to-day job. You're doing, as Lisa's mentioned, we've got 1,400 patients in our EDs coming through on a day, it's massive. And then you've got all the issues with like mental health patients that are all taking our side rooms on our AMUs and EDs. You've got your P2 beds that you can't discharge to. But having that ability to get that kind of data, you can do all kinds of stuff. So for me, it would be that. Maybe it's because I'm a scientist, but I think it's probably would help me to do a lot more other things. I've had that readily available. You can manipulate it to get those kind of interventions. Your mouth care matters. You know, if the ICB say I'm getting rid of your mouth care matters team, well, you go, well, that's what it benefits. Look at the amount of like HAPs pneumonias we're preventing and that kind of stuff. You know, you can't argue that.
Yeah.
What are you going to do? That's how much money it saves. Kerry gave a great talk on procurement and looked at like value. Value added? Yeah, that's the chestnuts. But it's what you get the value for. If you can show that kind of stuff, it might be more expensive, but you're showing you can do all of that. And I think we do need that kind of data. It brings it back to what you said about surveillance. You know, if we don't know what we don't know, do we?
No,
so that's for me.
There's a million things we don't know. Who else wants to spend £1 million? Stephane, what would you spend £1 million or $2 million on?
At least $2 million. I would want to would design better outbreak management system for residential aged care homes where we don't lock people up in their room and we actually talk to the people and trade off what we can do. So we're a little bit more compassionate in these settings because I think COVID showed us that might have been lacking at some point. And understandably, you know, we wanted to keep people safe, but did we do a bit too much in restrictions? And, you know, did we actually talk to the people and see what they valued? So I think I would want to do that. So it's a little bit outside of your question because it's not microorganisms specifically, but it's really, you know, because I think we could do a lot better in these settings.
It's definitely going to be a growing sector, isn't it? More and more people are going to be in that sort of situation. So, yeah, Lorraine, you've got £1 million. What are you going to do with it?
Yeah, because I'm quite a greedy person. I think
obviously.
I'd split it. Yeah. I love that. That's a really good idea. Now, I'm going to split it 3 ways. So I'm going to probably put a couple of 100,000 to safeguard my team as my SIP. Here you go. I've done it. I would steal Steve Ham's idea about really focusing on the public's hand hygiene, hand washing, like throughout the whole country. So not just in a little area. So do talk to Steve, he's got some great ideas about that. But I think that would, again, turn the dial. And I think I would spend a third of it on working with children. I think we've got to get a generation of people who get this and that we're not doing the same reactive stuff with them when they are a little bit older.
I once read a paper that said if you didn't get good hygiene standards into a child by the age of 7, you've got no chance at all. So I blame the parents of orthopaedic surgeons the world over. Kerry, you got £1 million. What are you going to do with it?
I feel like I'm going to be cheeky and split it as well. I think there needs to be, for me, it's the investment, particularly in any kind of harm prevention-based practitioner in behaviour change. Because I think a lot of us know the standards, but we don't quite know how to change people's behaviours and how to do that effectively. And that kind of aligns a little bit about how we know how to tackle and address health inequalities, because those are the patients often that are the most vulnerable, people that are the most vulnerable that need that support and intervention. So I feel like we need to learn a lot from our public health colleagues, because often they know how to support behaviour change and prevention and how to address that in the most vulnerable in our society. So I probably need a lot more than £1 million, but that's probably what.
It's a good bid though. Moira, where would you spend it? I mean, educational initiatives or something else?
I think we have some issues with our education of our healthcare workers in general. I think we should have standardised education for infection control embedded in evidence-based practice manner for every single healthcare worker trained, from doctors, physios, dietitians, anybody who's working. And we should all be getting the same training, so we're all singing off the same hymn sheet. I think that is a problem. And because people come and they work in the clinical setting, they're coming into a setting where people have habits and behaviours that are embedded for 20, 30 years. And this is the way we do things here. And that kind of attitude, I think, makes it very difficult for anyone, even if they get the education, to change, because it's very hard to push against your peers, senior peers particularly. But I think we could embed that education also in primary schools, as Lorraine said, in secondary schools, and with the general public. Because I think if we can get that vaccination, mouth care, hydration message fully out there and people can accept it and understand why, I think we're going to significantly potentially reduce hospital admissions by a whole lot. And the other thing I would like to do, because I am also greedy, I would like to do a valid repeat of something like the Cynic study. I would really like to be able to say, this is how many IPCNs we need for this setting, this is the evidence, and you need to resource it.
Okay. Going on that theme then, we've got about 4 minutes left. Quickest answer ever. You're about to lose a team member, so the £1 million hasn't worked. You have to stop doing one thing in your team. You have to stop one activity. What would you not do anymore? What could you lose? Go on, Mark. You go first. What would you lose?
Hand hygiene audits.
Yes. I was rather hoping that one might. Lorraine, what would you stop doing?
Fit testing and hand it to those that should be doing it.
Okay. Stephane, anything you would stop doing from an infection prevention point of view? It's a tricky one for you.
It's very tricky. I'm not. Can I?
Well, maybe you should stop doing prevalence studies in Australia. Oh no, you don't do them anyway.
No, yeah.
Kerry,
we're doing one at the moment. Martin.
Do one, then you can stop it. Yeah. Kerry, what would you stop doing?
Oh, I was going to say there was one about fit testing and things. What were you wanting to think about it?
I'm under severe pressure because I'm not working clinically, but I do think we need to segregate infection prevention and control from occupational health. I think we need to collaborate, we need to work together, but they are different jobs. And it is too much to expect someone to understand and apply and double their work. And I think that is a huge, huge challenge for people and causes a lot of challenging, I suppose, conversations. So I think that might be something.
Thank you.
It's basically everyone's job that should be doing that. Other than our own.
We do lots of other people's jobs.
That's probably what I think. Yeah. I think that's a summary. Maybe things like doing things on such an individual basis all the time. So like things like policy writing. We almost spend hours and hours writing our own policies. So,
GPTs.
I know, exactly. So what? I mean, I know we have to do localization of stuff. Maybe mandatory training as it currently sits. Then writing that stuff.
Okay. Well, you need to make that more interesting, I think. Right. Okay. Well, in that case, thank you so much to everybody on the panel. We've had a nice chat. I'm afraid you guys didn't get to join in very much, apart from Lisa. Thank you very much. And we'll close the session now and hang on around, please, for Jude and the final awards and the close of conference. Thanks very much for listening and staying.